Good afternoon, everyone. My name's Emma Dickens and I'm the Integrated Care Manager for Sydney Children's Hospitals Network. Today I'm presenting on behalf of a number of people, those listed on the screen, and also the SCHN Integrated Care Asthma QI project team. Today I'll be presenting on our Integrated Care initiative to improve management of paediatric asthma. So just a little bit about Sydney Children's Hospitals Network. It is the largest tertiary paediatric service in Australia and comprises two hospitals, the Children's Hospital at Westmead, which is on the top left, and Sydney Children's Hospital Randwick, which is down by the beach. And there's roughly 40 kilometres travel distance between the two hospitals. Each year, our services manage 51,000 inpatient admissions, 92,000 emergency department presentations, roughly, which includes 1,500 presentations for asthma at Randwick, and over 1 million outpatient service visits. SCHN was chosen to be an integrated care innovator site by New South Wales Health, with asthma being a target area. We developed an integrated model of care to improve post-discharge follow-up of children with asthma or viral-induced wheeze who were not admitted, and this presentation is based on the SCH Randwick experience. So firstly, we're going to start with Sam. Sam is 5 years old and diagnosed with asthma. He has presented 6 times to the Emergency Department for Asthma Management in the past year, approximately every 8 to 9 weeks. Sam's parents get confused about following the asthma action plan. They have 7, give Ventolin when it is not required, and give Sam leftover prednisone as that's what the hospital did last time. Sam's asthma is usually triggered by viruses. The families see their GP regularly for other issues, but don't go to the GP for asthma-related issues, as it happens after hours and they trust the hospital. There are issues with communication between the school and home around asthma management, and Sam regularly misses school. The family were anxious and weren't confident in managing Sam's asthma. So we wondered whether Sam was the only patient like this, or was this a common scenario? We identified 60 children across both of our hospitals and found that they represented a total of 581 ED presentations, of which 449 were asthma-related within 1 year. On average, this equates to roughly 10 ED presentations per child per year, of which 7 of these were related to asthma. Unscheduled hospital presentations were a marker of poorly controlled asthma, a significant burden to the health systems and families. Following hospital presentation, the New South Wales Clinical Practice Guidelines suggest follow-up with their GP within 3 to 5 days. However, many children only have their asthma reviewed in hospitals when there is an acute attack, rather than having a planned GP review. So we surveyed the parents of these 60 patients, and they identified that the hospital predominantly manages their asthma. The majority of children had an asthma action plan. However, in most cases, this has been issued by the hospital. And not surprisingly, most presentations were after hours, which coincides with clinics and GPs being closed. We also looked at the journey for patients presenting to the ED with asthma or wheeze. And one important finding was, when mapping this, was when patients are discharged and advised to follow up with their general practitioner in the next few days. We don't know if families do this, but what we did know was that they were re-presenting to the emergency department. Based on this background, we developed our aim: to reduce representations to the Sydney Children's Hospital ED of children aged 2 to 16 years with asthma or viral-induced wheeze that does not require admission and are frequent representers by 50% by December 2017. It was determined that children who represent to the ED 4 times or more in a year with asthma and then discharged represent a group who do not have optimal care or support in the community. So a little bit around our method. The project commenced in 2016 and first looked at international research on care coordination for asthma, along with international evidence-based asthma guidelines, which identified 3 key areas known to improve asthma management and decrease likelihood of patients representing to the emergency department. These included medical follow-up, parent and staff education, and asthma action plans. Coinciding with this work at the time was a network-wide approach to care coordination, which my colleague Yvonne will be speaking about in this session and also tomorrow, with this project looking at a particular patient population. We assembled a multidisciplinary team and developed key partnerships with community groups and non-government organisations, consisting of clinicians, nurses, managers, consumers, primary care representatives, including GPs, practice nurses in the primary health network, and researchers. We developed our aim, identified solutions using QR methodology, such as driver diagrams. So the driver diagram on screen highlights the number of change ideas that the team came up with, but we identified the most impactful and easy to implement change ideas, the low-hanging fruit, to be tested by PDSAs that would address our aim. Some of these PDSAs included children presenting to the ED with asthma or viral-induced wheeze 4 or more times in a 12-month period and were not admitted, were flagged in the electronic medical record system. Care coordinators contacted the parents and requested that their child have a review with their GP, and also offered referral to asthma education sessions. Education sessions were provided for GPs, ED staff, and parents of children with asthma. They combined presentations, hands-on practical elements, interactive discussions, and individualised guidance to each parent. Resources for home management, childcare, school management, and contact details for ongoing support and information were also provided. A letter was also sent to the child's GP by the care coordinator, advising of the child's recent hospital presentation. This letter contained asthma best practice points, encouraged influenza vaccine, review of the asthma action plan, preventive medication, and referral to a paediatrician if necessary. Another PDSA where parents were also given a standardised New South Wales asthma viral-induced wheeze resource pack upon discharge from the emergency department, which included individualised asthma action plans, asthma information pack, and discharge instructions, including recommended follow-up with their GP. Project team members were allocated to the PDSAs to test the change ideas. So during December 2016 and February 2018, a total of 57 carers of children were contacted by the care coordinators. We used this run chart on screen for constant monitoring and to measure where the project was achieving its aims. The median age of the children was 4 years, with the interquartile range being 3 to 5 years. And the median number of emergency department presentations in the 6 months preceding enrolment in the program was 2, in post-enrolment was 1. So one of the big outcomes was that there was a 57% reduction in number of children who presented to the ED 4 or more times in the 6-month period post-implementation of the program. However, there are some limitations to note. We don't have a control group for this intervention, and asthma is also seasonal. However, we're also at the stage now that we're beginning to look at 12-month data. So some of our lessons learned along the way. This initiative is sustainable as it's now been adopted as routine clinical practice within Sydney Children's Hospitals network. It's provided useful data for further rollout and testing, and the team believes there is the opportunity for translation to other specialties. It's continually being evaluated via ongoing data collection, and when the team meets monthly, we review this data at every meeting. It's provided a comprehensive integrated approach to asthma management, and it's a great example of multidisciplinary and multi-agency teamwork, allowing to share expertise, understand all viewpoints, and effectively implement change. As this initiative is now routine practice, the future direction is looking at frequent presenters, which include 1 or more hospital admissions. Similar to the methodology already described, the group has completed another driver diagram for this cohort and are currently undertaking PDSAs. The original group has continued and continue to champion change in our organisation and externally, along with enhancing links between the hospital and community. The integrated care team has now been able to step back, with this project being driven by the respiratory department. Additionally, we also have now 2 GP reps sitting on the project team. So outside the questions today, if anyone has any questions that I can direct to the appropriate project team member, our integrated care email address is up on the screen, and if you're interested of having a look at the Asthma in Your Child resource pack that is provided to families, if you search for what's on the screen, you'll be able to find it as well. Thank you.